On behalf of the Asfari Institute for Civil Society and Citizenship, I welcome you all to today's conference on SRHR. I quote from Stanbury, an intersectional feminist activist, that SRHR give women the possibility to make autonomous decisions about their own bodies and sexuality. They keep women healthy, dignified, and safe. Access to sexual and reproductive health and rights is extremely crucial for young people. It provides medical care and comprehensive sexuality education, which give them vital information about their sexualities, sensuality, and gender identities and expression. It also allows them bodily autonomy and power over their lives. Having access to sexual and reproductive health and rights can decrease child marriage, decrease teenage pregnancies, and prevent transmission of sexually transmitted infections. SRHR is a topic that affects so many different realms of people's life. Please note that the conference is recorded. If anyone wishes not to be recorded or taken a picture of, please identify yourself now. Thank you. I would like to also remind you that we are here in a safe place. We should all respect each other, and no one is to be exposed to discrimination, criticism, harassment, or any other emotional harm. Please respect that. Finally, I hope you can all learn greatly from today's panels. Our keynote speech for today is by Dr. Faysal El Kak. Dr. Faysal is immediate Vice President of FIGO, a director of the Women Integrated Sexual Health WISH program, and a clinical associate of OBGYN and Female Sexual Dysfunction Department of OBGYN at the American University of Beirut Medical Center, AUBMC. He's also a senior lecturer of health behavior, sexuality, and public health at the Faculty of Health Sciences at AUB. He is involved in clinical and academic research services at both academic and community levels. This includes running a community clinic where he works on services, research, and advocacy related to Syrian refugee health and marginalized Lebanese in the host community, especially women's health. Dr. El Kak has published 2 books on maternal mortality and several book chapters, as well as many media articles and appearances. Please join me in welcoming Dr. El Kak for his keynote speech.
Thank you. Thank you very much, Rita. Thank you for being here in person and online. I'm glad and thankful to Asfari Institute for this opportunity to be talking about globally important and the globally evolving topic, which is the SRHR, and in specific, the importance of SRHR as a discourse in youth social inclusion. I'll be talking about the evolution of the trajectory of the SRHR and the changing landscape in the region, and touching upon the transnational study as the title of the invitation to this morning webinar seminar by Asfari, and share with you some of the recommendations. If you Google SRHR definition, you will come up with 73,000 results in almost half a minute. No, not half a minute, half a second, 0.35 seconds. And that means this definition is always changing, and it's always perceived kind of differently with different meanings in different communities and by different professionals and careers. But the truth is, it all began officially coined and understood in the ICPD 94, the International Conference on Population and Development in Cairo, where, as you can notice, the global community have worked to define and coin the term and put a plan of action for its progress. And since then, there was many advances here in the region and globally, and of course, a lot of setbacks. ICPD 94 is probably one of the most influential and game changer conference that focused on the individual well-being for the first time, not the community well-being or the public. It looked at the individual within the perspective of respecting human rights and the freedom of choices, and was something really advanced. In particular, there's a very special position for sexual reproductive health in ICPD, and this is the definition developed then at that time, looking beyond the physical aspects to include the social and to include the mental well-being in matters related to sexual reproductive health, and that was very advanced at that time. It also carried an implications that it has to be satisfying, ensuring satisfactory and safe sex life, and again that was avant-garde, and at the same time allowing people to have the capability to reproduce and the freedom to decide if, when, and how often they're gonna enjoy their reproductive life. So the new landscape following the ICPD is we moved from dysfunction in relation to health to well-being, which is very important, and important in not only in the medical public health, but also at other social science and anthropology fields, because it looks at the bigger picture beyond dysfunction. The other also new thing changing the landscape is the rights framework to ensure justice, especially those with the inferior consideration. Reproductive rights and gender equality here, they are not like social determinants as you start counting other determinants, but exactly they are at the heart of the SRHR outcomes and as important ends and targets that you seek to achieve. The features in this new discourse is that SRHR now is a measure of development and not only of health. And to those of us who, are into the whole language and literature following ICPD, this is very important. It's very important because now you're talking development, you're talking justice, you're talking equity and equality. And there is a shift from the medical to the holistic aspects, taking into consideration all the social challenges, and at the same time, it is, as I said, individual well-being driven. Okay, which means now you see every individual in their own characteristics, which later will play an important role in the consideration of justice and gender equity and equality, and also the rights respect. And for that reason, you can imagine that there will be engaging of wider actors beyond health professionals. There is social scientists, policymakers, engineers, all types of stakeholders. The connection to the SDGs that took a lot of thought and analysis is again obvious. SDGs is now considered to be the global umbrella to really guarantee development using all aspects from health and other disciplines. At the heart of the SDG 2030, there is the advancement of the ICPD vision, more so in the challenge that was set by world countries around, or governments, around leaving no one behind. And that continues to be important, at least in terms of the UHC challenge, which is the universal health coverage. Leaving no one behind means including all those historically and chronically marginalized or neglected, of course, namely women, young girls, and children. And also the issue of equity and development, which is also represents a strong connection between the ICPD and the SDG 2030. In specific, if you look at the SDG goal 3 and 5, 3 is about the good health and well-being, and 5 is about the gender equality. You can see that under 3, you ensure healthy lives and promote well-being for all at all ages. For all meaning irrespective of their sexual identity, orientation, preferences, where they are in terms of their ethnic affiliation, religious affiliation, and community affiliation. And for the goal 5, achieve gender equality and empower all women and girls. I know that some people they don't like anymore the term empowerment, but this is what the goal 5, even if we disagree on terms, but we all agree on really ensuring gender equity and equality, and that we mean to refer to women and children. So the ongoing work on these different and separate important agendas, whether it is sexual health, reproductive health, sexual rights, reproductive rights, have led at the end to a comprehensive definition around the SRHR, which was very well exemplified by the famous Lancet Commission on the SRHR. And although they used the introductory definition of the ICPD about SRHR going beyond health to include the social and the mental and the psychological and the emotional well-being, but also they emphasize something very important and something that really galvanize around efforts of many people in this room and globally, which is a positive approach to sexuality and reproduction. Okay, and that approach should recognize the part played by the pleasurable sexual relations. Do not underestimate the whole introduction of the pleasure and the pleasurable experiences in this whole landscape of sexual health and sexuality. It's something very important because you moved from satisfying sexual relationships in 1994, which means nothing. Satisfying means nothing. Are you satisfied with this coffee? Yes. Yeah. Are you satisfied with this experience? Yes. What does it mean? Nothing. Okay. Versus pleasurable, which is more active word. It's a word which is more positive and engaging. It engages the person with herself, himself. It engages the partners together or more. So it's a pleasurable sexual relationships. There is trust and communication in promoting self-esteem and overall well-being, which is a humanizing sexuality and sexual health. And that exactly mirrors the definition that I was part of the expert group that we defined sexuality and sexual health. And that was about humanizing it, positioning sexuality and sexual health as a central aspect of being a human, in contradistinction to all the historic shaming and naming and dirt and sin and stuff of sex and sexual health. So this carries a lot of important positive aspects around the SRHR definition. All individuals have a right to make decisions governing their bodies and to access services that support that right. And in that regard, the Commission recommended two main if you want, aspects or dimensions. The one is about the frame of rights, sexual reproductive rights, for this definition to work and its implementation to work. And the other aspect is an essential package. There should be an essential package to push this whole understanding of SRHR. Of course, the issue of rights is very contested in certain aspects. In many places, people do not approve or clear the aspect of sexual rights in the sense of the right to be in a relation and the right to leave a relation and the right to decide on your sexual choices and preferences. Of course, other issues are okay for everybody, but still others are contested because of the, again, traditional and chronic attachment between what people believe is a community values and the traditional values and the sexual freedom. So far, people need to adjust and work around this, and this will be I will keep some discussion around this till the end. And the other dimension of this SRHR understanding is the package, the service package. And the package here, it's not only about a service that you provide, which is very important, and that's what we do also in our life. But there is more beyond, again, the health and dysfunction. There is the comprehensive sexuality education, which is very instrumental and important. There is the issue of identification and prevention, for example, of gender-based violence, of sexual violence, and all these aspects, the issue of around safe abortion and post-abortion care, okay, and of course, the whole range of prevention and health maintenance. Although these are obvious direct services that we're supposed to provide, but once they are provided and are implemented, it means a lot in terms of inclusion, access, equity, confidentiality, privacy, and that is a major thing in pushing SRHR as a concept, and as a path, and also in including youth in their various preferences. And they left a roadmap. I called it broad map. So all I did is adding a B. The roadmap or the broad map out of this Lancet Commission is to focus on 3 aspects, among other things, but I think these are highly needed, if you want. The adolescent young people, which in many places are left out in terms of services. The gender-based violence and the sexual violence, and engaging men not only in supporting partners when they have female partners or even male partners, but also in supporting men as men for the services they seek, and again, not to be left outside. In the context of the region, of the MENA region, and can see that there was an active participation in 1994, and in 2013, the Cairo Declaration to move forward on the plan of action of the ICPD 94 again showed a lot of positive and favorable achievements in certain aspects. In 2018, a review of the progress conducted by some of the UN agencies and some of the researchers in Cairo again revealed advancements, favorable outcomes, and of course, setbacks. ICPD 25 in Nairobi, Kenya, again, there was a progress following 2013 and 2018. So if you want to look at the track from 94 to, as we speak now, 2022, you can say there are favorable outcomes on certain aspects, ratification of international frameworks, establishment of high-level councils in relation to SRHR, changes in some legal frameworks that will ease that will reduce discrimination, marginalization. And also there was some effort to formulate strategies and the programs for the protection of women. This is a table I just put to show you some examples. This is from the document we prepared and reviewed under Asfari inter alia, if you want, for the study that we can highlight a little bit. In this overview, you can see that all countries under review, which is most of the MENA countries, ratified the Convention on the Rights of the Child. All countries under review, except one, ratified the Convention on the Elimination of all forms of discrimination against women. But Tunisia is the only country to have removed all reservations to CEDAW. Within the national legal frameworks of all reviewed countries, the right to education and the right to equality and non-discrimination are both specifically mentioned and safeguarded in national constitutions. On the other hand, so you won't be very happy, none of the countries except Morocco, however, are committed to the right to decide the number and spacing of children. Of course, you can mention other aspects like polygamy. Tunisia is the only place where polygamy is criminalized. The issue of abortion, the issue of post-abortion care, then you come to wages, you come to divorce, custody. So there are some improvement in certain aspects, but there are also still something lagging. This is, for example, some of the measures to address the newborn and maternal mortality. The dark dot is there are some existing policies, and the empty circle or the empty dot is there is nothing happening. And these are the countries, and you can see, and just to make it, there are things happening in some countries, but still in other countries, things are not happening, especially in relation to the ability of the woman to take charge of her reproductive destiny and family planning. If you look at this measure on reproductive and sexual health and of adolescent, for example, many countries, they still have no existing policy for the minimum age of marriage, marital status, emergency contraception, which is the simplest thing, something, it's like a form of birth control pill. Again, about permanent methods of family planning for women or for men. These are simple measures that are part of the overall advancement of the rights are still lacking. And of course, the issue of abortion, it takes different interpretation for its indication in different countries. The most retarded one remains Lebanon in this regard and Syria on abortion. Yeah. In terms of the services, we have some of the favorable reviews in the region. We have more integrated services now. We're going more beyond pregnancy and childbirth to include sexual infection and other services. And there is some quality improvement, and more people are able to access these services. This is the services existing at the primary healthcare level, which is, again, this is now. If you compare this to 25 years back, all these checks will be absent. So more services, more integrated services are existing at the primary healthcare level. But why we are still lacking some of what we need to push forward the SRHR? One is the lack of the political commitment, either because the existing governments are not convinced with the whole spectrum of SRHR and what does it need, or because of competing priorities, probably development issues, war issues, security problems, natural disasters. The other thing is about the thematic challenges For example, we're still struggling with the issue of the whole sexual health mandate in terms of screening, resources, knowledge, provision, and stuff like this. And of course, issues of inequality and inequity. These are the three decelerating determinants in this regard. With this whole description of what's happening, you cannot but see that adolescent and young people are probably the most suffering, if you have to use the word suffering, and the most who are marginalized, despite all the reported progress. A lot of people argue, and I think we are convinced with this, at least I am convinced with this, is that there is a lot of benefits, health-wise, development-wise, in investing in young people. One, because you have probably more than 2 billion people on planet Earth. And if we continue, since we all agreed on the agenda of development and progress as by SDG 2030, we have to invest in young people's health and to give them priority and also engage them in all the processes related to the SRHR, whether theirs or in general, and ensure access for all adolescents and youth, especially girls, if you have to be honest to the ICPD 25 in Nairobi. To look at this, one of the interesting models or frameworks is to look at the one which is about multifactorial inequality framework. Because if you look at inequality, people believe, because if I convinced you now that we have to engage youth and invest in youth because there is this issue of inequality, then you have to ask yourself what kind of inequalities we are talking about. Well, this is a model that looks at 7 aspects of inequality. And this is about health, security, education, financial stability, living conditions, participation, influence, and voice, which is this component is a core element of the transnational study that was conducted, and also about individual, family, and social life. And if you look at this for a second, you can say that most likely that young people, definitely they suffer at all of these levels, and especially the participation, influence, and the voice, to be part of policymaking, of implementation, or of other content development. So according to this model, the inequalities are manifested not only in relation to adults, but also within youth and young people. Looking at MIF aspects and being cognizant of the global momentum around SRHR as a goal to promote rights, justice, equity, health, and well-being, it makes a lot of sense that to use this model in pushing research. It's prudent to look at young people socio-political status through the lens of SRHR. That's why this study came in timely to look at the how SRHR as a path can help in the inclusion in the of youth in the MENA region, which was conducted under the Asfari Institute in these countries that you see on the screen: Egypt, Iraq, Jordan, Lebanon, Palestine, and Tunisia, targeting young people between the ages of 18 and 35. You want to map and capture these inequalities in these countries in this research. You want to provide knowledge on the current inequalities that are hindering the full realization of SRHR, focusing on those category of young people. At the same time, you want to answer two questions, one around the progress in claiming SRHR in targeted Arab countries, and on social inclusiveness in these 5 countries using different methodology. What are the findings? The findings with the focus on the inequalities and inclusiveness really crossed along 6 or 7 themes. At the level of the knowledge among youth, there was inequalities. In the prevalence of health concerns, in the access to the services, in the quality of the services, and also at the level of the challenges and opportunities, as well as in the perception of the youth to the level of exercising of their rights, to the civic space and engagement, and to the legal frameworks and instruments. At all these 7 levels, the study captured inequalities, which was one of the main purposes of the study. And if you look, for example, at main themes around the findings, there was inequalities in terms of gender, marital status, geographic area, economic status, and sexual orientation. That will be highlighted by my fellow panelists later. But for example, this issue of inequality, it's at multi-levels. It's not only, for example, at the level of the service itself, having certain services, others are absent, but also, for example, at the rural-urban divide, at the married, non-married divide, at the hetero-homo divide. So there is compounded, if you want, compounded inequalities at these various levels. Also, obstacles impeding access to SRHR in terms of the laws, in terms of the environment of the service, in terms of the characteristics of the service. Young people hold government responsible for the complete or comprehensive sexuality education, responsible for the training, upgrading of the healthcare providers and of the services. And it was reflected that people have very low levels of trust in these public services. The young people perceive that NGOs are a strong ally and supporter in terms of making their voices heard, in terms of giving access to resources and services. And also young people, they feel they are challenged to take action and make their voices heard. And that's where we need to be supportive. In terms of recommendations, out of the study, you have 2 levels of recommendation. You have the level which is like every lecture has to end up in recommendation, which I don't like very much, because you have to give recommendations, and most of the time they don't work. But these are at least some of the recommendations that we leave. It can work. Of course, continue doing research. Of course, identify more relevant stakeholders to work with, whether for funding, whether for youth mobilization, whether for the policy making. Youth-friendly services with youth-friendly standards and bias-free. Upgrade healthcare provider through training guidelines and supervision, using life cycle approach to provide services. Make sure that the health information is more safe and secure. So you encourage young people to trust the service more. Promotion of the available service and making them more integrative. And build the capacity of the government agencies whether in terms of planning, in terms of being sensitive, in terms of fundraising, and in terms of giving importance to youth and their health and other issues. Maximize the role of NGOs in relation to SRHR. Okay. Also include marginalized and often neglected populations. Develop and execute advocacy campaigns that promote non-discriminatory SRHR service messages, okay, and make sure future research will include wider population, even within the young people themselves. My level 2 of recommendation. So we said there are 2 levels of recommendation. I will just end with a few slides that are probably some foods for thought. This is an image of pregnant women from different communities. And if you look at this 95%, this is the number that tells us that 95% or more of the pregnant women will be followed up by a healthcare provider and most likely will deliver in a hospital. Okay. Then at this slide, less than 30% is the number of women after delivery and later on in life will be able to seek service. Why is this huge difference from 95 when they carry a baby to less than 30%, sometimes 10 or 15% when they are outside their reproductive or pregnancy childbirth years? Because of the value we give to fertility. This is the tree of fertility. But if you look over the past 25 years, the total fertility rate and the crude birth rate went down almost by ranges of 40 to 80%. It went down. You were able to shake this whole value that a community gives to fertility, and the value of the woman is not really complete unless she is in a reproductive union or with children. This has changed. We moved down from total fertility rates of 3, 3.2, 3.5, almost to like 1.2 or 1.1 and 1.3. How we're able to do that? Because we have shown, or it has been shown, that there is more vested interest and there is more benefits to the individual and to the community on education of girls and women. The whole economy issue and the feeling of being like, less children means more abilities to educate them, raise them properly, have more time, have more resources, okay? And the issue of religiosity, when they start seeing that raising a well-educated child or a well-brought-up child is religiously more relevant than like having 5, 7, or 10, and not being able to give them the time they need. Also, more acceptance of contraceptive use, and definitely more and more family planning programs in different countries. And this has been shown by 2 recent papers. You have many papers, but these are very interesting 2 papers showing that the issue of wealth, when you start feeling the wealth and the income, you start thinking less of fertility. The quality education, okay, youth participation, that was a key thing. See, when you have less children, I'm talking about the research outcomes, and you are able to educate them better and bring up them better in their perception, then they are able to do more, to participate more, to go to college, to work, to contribute, okay, in a different way. So For the government and for the family, that helped very much in the issue of youth participation. This is another paper, again, showing that the childbearing and the number of children are not only connected with the interpretation of individual about conditions and factors surrounding them, but also linked now with the factors such as family income, amount of time parents allocate to their children, quality of child nurturing, and other family variables. And these are important game changers in shifting the fertility. I was telling my friends yesterday, this is, I read in the newspaper yesterday, Sharq al-Awsat. This is the president of Egypt saying that إن النمو السكاني سيأكل البلد. So he's using an extreme statement to push the issue of family planning and contraception in Egypt. سيأكل البلد. And there is no بلد. If you eat something, it does not exist anymore. And there is this campaign, حقك اتنظمي. Now they're talking about rights. So they're telling the woman, it's your right to birth space, and it's your right to postpone a pregnancy, which is the IPPF mandate of postponing, delaying, and spacing. Okay? So this is very important, how much this is going to be working and how much this is effective. I'm just talking about the changing language. And that's why we should be able to develop a similar argument to engage more and more young people and to convince governments and societies that they have more vested interest and more benefits if they invest in SRHR. Okay? Because the young people we're talking about are educated, activists in the labor market, and they have their say, and these are important to allow all these voices to happen. And this interesting review on youth matters and investing in young people, they came up with a conclusion or recommendation around the importance of expanding services to cover abortion, post-abortion care, and violence, because these are key issues, of course, in addition to issues related to the young people of sexual health and what it relates to in terms of education, counseling, and screening. And the other aspect is the comprehensive sexuality education, because there where you build knowledge and you build a solid platform within each and every one of us, and of course of all the young people, that will help them decide and make choices in their lives. I want to thank you for being here and for listening, and I'm happy to take, if time allows, any questions. Thank you for the question. This is a report from the ASRO, from the UNFPA and the Arab region, that contacted the governments, and the government supplied them with the what's available in their documents. I spent in Iraq almost 4 weeks, I think, last year, upgrading their adolescent health programs in the schools and in the services. And I received documents that contain reproductive health aspects that was upgraded by, I was supervising this with all the responsibles of the muhafazat then. Whether this is being instructed in details in the classrooms or in the services themselves, it's up to them, but there are things that are present there. And as I understood from some of the المدير الصحي بالمحافظات وهيك, إنه some of the services are being available, others, as you said, are not being available. I am sure it's inconsistent, I'm sure, as you said, but at least there are things that are there, and that's why you are here. We need to push these things more and more, and but basically these reports are based on what the government provides to the UN agencies. Thank you. Yes.
I just wanted to reflect on this point in particular. When it comes to laws, usually their existence is seen as a success. And I wanted to ask you as a healthcare practitioner or healthcare provider, to what extent have laws been helpful to you in practice, or have maybe eased the way to access services for certain peoples? Because we already know that a lot of laws are put in place, but they are never really implemented. So maybe if you could reflect on that, it would be great.
Thank you very much. Very good question. Well, laws, definitely, they are tools that legitimize a certain act or a certain implementation. That's why you have the laws. But definitely many of the practices are happening, if you want, outside the law. For me as a practitioner, definitely having a law that legalizes some aspects of interruption of pregnancy, having laws that legalize providing services and giving full access to LGBTQIO communities, for example, providing screening of sexual infections and counseling for all types of people, irrespective of their social status or gender status. That will give me more easiness. We're doing this in the private practice, of course, every day. We do this. But at the same time, this will only privilege certain people who have access to private practice. The benefits of this is when you are normalizing the talk about sexuality and sexual health issues. You normalize the talk about interruption of a pregnancy. You normalize the talk about premarital sex if people choose to do so. So the one of the positive aspects of the law is you normalize this. Now there is a law which is impartial around protecting women, the 2013 one, from domestic violence. How many women will go out and say, I am subjected, I'm a survivor of violence, and this is my assailant, and you're gonna do this or that? I don't know, probably they will think about it, but at least there is a law there if you choose to do that. So for the services, the laws are important because they give people more comfort in going and seeking care instead of doing it. And do you know somebody that knows somebody that knows somebody? But that again will continue to be for the privileged people. And the privileged people will always find ways outside the law. So we want, on the other hand, if you are talking inclusion, you're talking about those that are underprivileged and marginalized, to have the law on their side to protect them and give them safe access to these services in that sense. Thank you.
Among all the practices, I mean, you encounter, what is the most sensitive topic women encounter in relation to their SRHR? And as a medical doctor, which one you face most difficulty with, because the laws are not and the policies are not really in place to help the practitioners and the people from them?
Definitely, the most challenging one is the interruption of the pregnancies, undesired pregnancy, as a gynecologist. And definitely the issue around sexual dysfunction and pleasure. But interruption of a pregnancy is much more challenging for the woman and for the provider. One, because it's illegal unless under very strict condition, which is saving women's lives. But otherwise, it won't happen. And we tried, personally, I tried to make some amendments to this. Every time they tell you, it's not the time for this. مش وقتها. I tried 2011, 2012, 2013. We even talked about it. I even developed a document on post-abortion care for the ministry. I mean, I think the tolerance is there. There is tolerance. But again, you need to exactly to regulate this and like put the indications. And the other aspect, as I told you, is the issue around now you have to raise the bar for the knowledge and probably make women and people in general think around what does it mean to have a pleasurable sexual relations. We're trying to do this through the Women Integrated Sexual Health Program at the AUB Medical Center. We have an excellent advocacy platform. We are providing clinical services also for transgender, for LGBT, for the usual cases or the routine ones during pregnancy, after surgery, during cancer, menopause. But we're open to all. We're leaving no one behind, if you want, at the WISH program. But definitely, even accessing there, people still are not comfortable. So you have to create a lot of comfort, and that's through advocacy and building resources. And that's what we're doing, of course, with a few others in the community. And I think we need some time, but again, I think it's going to happen also. It's coming. It's coming. It's coming. Thank you.